It's the 7th of February, 2020. This is the RheumNow podcast, and I'm Dr. Jack Cush, executive editor of RheumNow.com. Heads up on head drop. What do you do with your itchy, scratchy urticaria patients, and what do they really have? And oops, found that synovial fluid in my lab coat pocket. How long has it been there? Oh my goodness, is it still good? Let's start off with that report, which is an interesting analysis of 30 synovial fluid samples, 18 with CPPD, 12 with MSU, gout, and they took the samples and stored them in either EDTA or heparinized tubes, and then they left them in either the refrigerator or at room temperature and assessed their viability of those crystals at days 1, 3, and 7. Guess what? MSU crystals are hard to kill. I mean, they were basically 92% viable for out to 7 days when they were at room temperature, and 100% viable when they were refrigerated. Again, they're really durable. CPPD, or the calcium pyrophosphate crystals, are less durable. They do pretty well, but they don't do well at room temperature compared to the refrigerator. They do better in the refrigerator. And they don't do well in EDTA. So optimal CPPD results are seen when they're in heparinized tubes and refrigerated. At room temperature, the viability goes down by 33%. Only 67% were able to identify the crystal at 7 days. Still's disease, and how do you assess when they're going to have a flare? Most of us would point to ferritin. You have to stop doing that, by the way. Ferritin is really nice and dramatic, but only in a small number of Still's patients. 50% of Still's patients will have an elevated ferritin. 95% will have an elevated CRP and sed rate. Which one you're going to look at? Hyperferritinemia is fabulous, but it's not that frequently seen, and it's got other causes for that too. Anyway, Tom Takeuchi's group in Japan studied 75 patients with Still's disease over a time period, and they looked at flare biomarkers. Of the 75 patients, 25 were not taking tocilizumab, and they had previously had been. 6 were on, others were on other drugs. They looked at AOSD flares and what happened to sed rate, CRP, and ferritin. Guess what? When you flared with Still's disease, sed rate, CRP, and ferritin were significantly elevated and were dynamic in patients who were not on tocilizumab. But when they were on tocilizumab, guess what? Not quite so good. Tocilizumab blunted the response of sed rate, CRP, and ferritin. On the other hand, white blood cell count and LDH levels rose whether you were on tocilizumab or not, and they were both quite dynamic. So they put forward that if you're following patients with Still's, white blood cell count, LDH in everyone, CRP and ferritin are helpful, but recognize they may drop or may not be as impactful in patients who are on the IL-6 inhibitor, tocilizumab. A nice Canadian study comes out of Calgary, and I put this up because it's the kind of stuff we see all the time, and it's what do you do with ANA positive individuals? It's a study from, I think, 2015, and they basically have this triage system at the university there, and they identified over a 3-year period 643 patients who were referred because of a positive ANA. About half the patients were seen by a rheumatologist, and this is what they came up with. 25%, 24% had the ANA that was due to an ANA-associated rheumatic condition, lupus, myositis, etc. Next, 26% had no disease, no nothing, no known cause. Third, 39% had another rheumatic condition, and they were quite vague about that. 11% failed to meet these autoimmune rheumatic disease criteria. I'm not sure what that was. What they didn't put in there was the number of people that had an ANA due to other disease associations that are not autoimmune or rheumatic. That would include, obviously, the number 1, which is thyroid disease, cancer, hepatitis, chronic renal disease, chronic lung disease, some drugs, etc., pregnancy. There are a number of things, obviously, renal failure. But nonetheless, I think it's an interesting study. And it actually says that not all ANA consults are going to be nonsense. Maybe as many as 25% will have a real disease. Difficult RA and its management comes up quite often. We're often at a loss for what is left in choices. Timely comes a report on the utility of Tacrolimus in patients with rheumatoid arthritis. A meta-analysis of 5 different studies shows that the odds of achieving an ACR20 response were significantly higher with Tacrolimus, 71% higher if you're on 1 to 2 milligrams a day of Tacrolimus, and 2.3-fold higher if you're on 3 milligrams a day. Unfortunately, this impressive clinical efficacy comes with a toxicity risk, mainly that in the way of renal risk. So the odds of bumping your creatinine are 2-fold higher at 1 to 2 milligrams a day, and almost 4-fold higher at 3 milligrams per day. So again, a good drug, you got to monitor. It's a lot like cyclosporin. Head drop as a symptom of myopathy. I thought this was interesting because I heard a foot drop. I've even heard a hand drop. Never heard a head drop. Thinking maybe I've seen a few people that are looking like this and don't know why. Well, 107 patients were reviewed and 53% had a specific diagnosis. That's somewhat encouraging, I guess. Inflammatory myositis made up 16, or that's about 15% of the overall group. Myopathy with rim vacuoles 10, radiation myositis, myopathy 8, nemaline myositis 7, myofibrillar myositis 4, fascioscapulohumeral, something that looks like polymyositis 3, and 2 each with inclusion body myositis or a mitochondrial myopathy, and even myopathy associated with scleroderma. So we have a few conditions on that list that can lead to a presentation of head drop as someone who has myopathy. So I teased with the idea of urticaria in your patients and what to do with this. This came up this week in clinic where I overheard the fellow and consult attending talking about a consult they're seeing someone who has chronic urticaria and now is in the hospital with an ANA and an FUO. ANA positivity with urticaria is not that uncommon and may not indicate an autoimmune process like lupus or myositis or etc. Anyway, a Danish registry of almost 12,000 patients with chronic urticaria looked at what their disease associations were. And as you might imagine, there was a fairly high overrepresentation of anaphylaxis patients and those with mastocytosis. But also in the list with healthy representations were atopic dermatitis, rheumatoid arthritis, lupus, thyroiditis, and vitiligo, all autoimmune disease. I don't know what that means for the consult with a fever and doesn't seem to have lupus, but nonetheless, it's out there for them to consider. A nice report compared the utility of MRA and FDG PET scanning in patients with newly diagnosed either Takayasu's arteritis or giant cell arteritis, and tried to show the differences as far as their presentations and what was found on imaging. The takeaway messages were that carotidynia and arm claudication were way more common with Takayasu's arteritis, and that vascular inflammation was easily picked up on by PET scan in Takayasu's arteritis. Much better than maybe what you would see with MRA, magnetic resonance angiography. GCA lesions were largely found by MRA and showed the evidence of damage more so than evidence of inflammation. This report sort of parallels a tweet from last week where I said, based on a lecture I was listening to, that MRA, much more affordable, much more accessible, is really good at defining the extent of disease and damage. On the other hand, PET scanning, very expensive, not affordable, often not covered, is really quite good at picking up on inflammatory lesions and generalized inflammation. And is also good in FUO cases if you can get it paid for. Had a nice report that we just put out about from JAMA Dermatology about which biologics are best in psoriasis. Not psoriatic arthritis, but psoriasis. And specifically, they looked at 60 trials with basically all the biologics. And it didn't matter whether you were looking at 16-week short-term outcomes or 60-week, one-year outcomes, long-term outcomes. that the drugs that fared the best were risankizumab, an IL-23 drug, guselkumab, an IL-23 drug, brodalumab, an IL-23 drug, and ixekizumab, that's brodalumab is an IL-17 inhibitor, and ixekizumab, an IL-17 inhibitor. With the PASI 90 results in the trials ranging from 74 to 79% between those four. The other IL-17 inhibitors, Cosentyx or secukinumab, are just behind that. Infliximab is pretty high on the list. Middle of the pack are things like ustekinumab and adalimumab. Bottom of the bucket includes tildrakizumab, another IL-23 inhibitor. Not sure why that is. Etanercept never did very well in skin compared to joints. And apremilast we know has a low level of response in psoriasis and psoriatic arthritis. But it's really safe. Congratulations. Our last report is on bariatric surgery as a means of avoiding rheumatoid arthritis. Well, obesity is a risk factor for developing rheumatoid arthritis. And obesity is also a factor in disease severity because patients who are obese are less likely to respond to a lot of DMARDs and a number of biologics. And it's not just volume and distribution. So even when you dose them according to weight, like with infliximab, obese patients just don't do as well. So this study in Scandinavia, it's a cohort called the Swedish Obese Subject Study, or the SOS study, studies 2,000 patients with obesity and their disease associations over time. They compared that cohort to another 2,000 patients who were not obese. And overall, amongst the 4,000 patients, they found 92 incident cases of rheumatoid arthritis. Guess what? Getting bariatric surgery did not prevent the risk of rheumatoid arthritis. That RA risk was the same whether you had bariatric surgery and lost a lot of weight or you didn't have surgery, and so that's sort of disappointing. What they did find was that CRP and smoking were associated with an increased risk of incident rheumatoid arthritis. That's it for this edition of the podcast. Go to the website. You can find the links to these reports. You can read more on these exciting articles. Check out RheumNow.live and our program. It looks really, really good. Let me give you one session. How about the session on spondyloarthritis? Advances in spondyloarthritis by Atul Dayadar. The gut joint axis, IBD arthritis by Artie Kavanaugh, and imaging in spondylitis by Walter Maximovich from the University of Edmonton. That's just one of many hours of great programming at RheumNow Live. We'll talk to you next week.